Good evening, everyone. Welcome all, first of all, and we have Dr. Sakshi Arora once again with us, and we'll be discussing image-based FMG questions. And this is for the second time we are doing it. And over to you, Sakshi ma'am.
Hi, students. Good evening to all of you. And sorry for the technical issue which happened on Friday. And for all of you who are joining us fresh and they couldn't join us on Friday, I am going to take up all the slides from the beginning, right? And as I told on Friday as well, this is an image-based session, which is especially I have designed for the upcoming June FMGE session. Now, in this today's session, I am going to discuss all the important images in OBS which are related to labor, which means I'm also going to discuss partogram with you in brief, right? So let's talk about the first image, which we already discussed the other day, but I'll quickly discuss it here again. So I'm going to discuss images more oftenly in the form of an MCQ. So here in the image, you have to identify the lie of the fetus in the following image. And the options given are option A, longitudinal lie, option B, oblique lie, option C, transverse lie, and option D, unstable lie. So what is your answer over here? Most of you, if you've attended, you know the answer. If not, then there will be a difficulty. Now, I'll deal with this question very quickly because that day I had explained in detail. What I am telling you here is, see, whenever you get a question on lie of the fetus, the first thing what you have to do is you have to see whether the uterus is centralized or not. Because in this case, if you say that this is a case of oblique lie, then that will be a big problem because this is not oblique lie because here the uterus is not centralized. Lie is relationship of the long axis of the fetus to long axis of the mother in a centralized uterus, right? So in this case, whenever I'm going to talk about lie, first I am going to centralize the uterus because normally in pregnancy, uterus is dextro-rotated. Why is it dextro-rotated? Because of the sigmoid colon occupying the left side, right? So the uterus is dextro-rotated. So with your hand, what you have to do is you have to centralize the uterus and then you have to comment upon the lie. Then you have to comment upon the fundal height, right? So in this case, I am going to move the uterus first. I'm going to centralize the uterus. Now, as you can see from the image, the moment you are going to centralize the uterus from oblique lie, your answer will change to longitudinal lie. So the answer over here is longitudinal lie. So I have all these images over here. In image A, the uterus is centralized and you can see that it's a longitudinal lie because the long axis of the fetus is corresponding to the long axis of the mother and the uterus is centralized. In image B, what we are seeing is that the uterus is not centralized. And this is the image which was shown to you in the previous slide. So first centralize the uterus and then you will see the moment you will centralize the uterus, it will change into longitudinal lie. So both image A and B are showing you longitudinal lie. Image C, what you are seeing over here is that the uterus is centralized. Still, the long axis of the fetus is making an angle to the long axis of the mother. So whenever the fetus is making an angle to the long axis of the mother in a centralized uterus, that is what is oblique lie. So image C is that of oblique lie and image D is transverse lie. Here, the long axis of the fetus is making an angle of 90 degrees with the long axis of the mother, right? So this angle is 90 degrees. So it is a case of transverse lie. Now, the important questions which you are asked over here are, what is the most common lie? The most common lie is longitudinal lie. In which lie is cord prolapse most common? Cord prolapse is most common in transverse lie. What is the management in case of transverse lie? If the patient is coming to you and she's in labor, whenever a patient who's coming to you is in labor and she's a case of transverse lie, the only management which you have is cesarean section, whether the baby is alive or whether the baby is dead. In either cases, you have to go for cesarean section. Please understand that there is no role of these destructive procedures in case of a dead baby with transverse lie in modern day obstetrics. In modern day obstetrics, we do not do procedures like decapitation anymore, right? So even if it is a dead baby with transverse lie, you are going to say that I'm going to do a cesarean section. If a patient of transverse lie comes to you at 37 weeks of pregnancy and all the circumstances are favorable, which means Liker is adequate, it is a single pregnancy, pelvis is normal, uterus is relaxed, then you are going to try external cephalic version, right? Now, oblique lie, the questions which they can ask you are, what is the most common cause of oblique lie? The most common cause of oblique lie is idiopathic. And the second most common cause of oblique lie is placenta previa, right? In case of oblique lie, also the management is cesarean section if patient is coming to you in labor, right? Now, next question is, a primigravida at 38 weeks of gestation in labor presented with the condition shown in the image. Best management is. So what you are seeing over here in the image is that hand of the baby is prolapsed, right? So it's a case of hand prolapse, and I can see that the cord is also lying outside. So most probably this was a case of transverse lie, and in transverse lie, this patient was made to undergo vaginal delivery. Now, most of the times this happens not in the hospital settings, but whenever a patient is getting delivered at home. So at home, the dyes, they try to deliver the baby, even if it is a transverse lie, and the only part with which they can hold the baby would be hand, and they'll try to bring the hand out. So whenever you see a hand prolapse patient, most of the times it is a case of transverse lie, and if there is a hand prolapse, the baby is already dead. And here in this case, you can see the cord is also prolapsed. And as I told you, in transverse lie, the only management is cesarean section. So over here, if they show you this image, it means that you have to go for cesarean section. Right now, in this condition, you are going to see that the patient is going to present to you in obstructed labor, because the dye would have tried to deliver the patient, but the baby wouldn't have delivered. So mother will be dehydrated. She will be having acidotic breathing, and per abdominally, you are going to get a Bandel's ring. Per vaginally, you will see that the membranes are ruptured. Vagina is hot and dry. There will be a foul smelling liquor which will be draining out. And you will see in this case, as you can see, the hand of the baby is prolapsed and the cord is prolapsed. But if it is a cephalic presentation and there is obstructed labor, you are going to get a swelling on the head of the baby, that is caput succedaneum. The important thing to remember is there are two kinds of swellings which can be seen on the head of the fetus: caput succedaneum or cephalhematoma. Caput succedaneum means it is a swelling which is happening because the head of the baby is there in one position for a very long time, right? So caput succedaneum is basically an edematous swelling. It's a generalized swelling which will pit on giving pressure. The very important point about caput succedaneum is that this swelling is seen above the level of periosteum. Whereas cephalhematoma is a collection of blood which happens in case of traumatic deliveries, like traumatic instrumental deliveries. And this collection of blood, obviously, it is not going to put on pressure, and the collection will be below the level of the periosteum. Right? So one very important difference between caput and cephalhematoma is caput is always above the level of periosteum and cephalhematoma is always below the level of periosteum. That's very important. Caput is an edema, so it's going to pit on giving pressure. Cephalhematoma is a collection of blood, so it's not going to pit on giving pressure. Third very important point which you have to remember is caput is because it is above the level of periosteum, so it can cross the suture lines. But cephalhematoma is below the level of periosteum. That is why cephalhematoma can never cross the suture lines. Caput will be present at the time of birth, and gradually within a few hours, it will disappear. Cephalhematoma will come after few hours of birth. So after 4 to 6 hours of birth, the cephalhematoma will appear, and it will continue to increase in size for 2 to 3 days after birth, and then it is going to disappear, right? So, right, in case of obstructed labor, if it is a cephalic presentation with obstructed labor, you can get a caput and you will get molding, right? So what is molding? Molding is an alteration which is there in the head of the fetus, right? So we have various grades of molding: grade 1, grade 2, and grade 3. Grade 1 molding means that the parietal bones or the cranial bones are just touching each other. Grade 1 molding can be seen in normal labor as well. Grade 2 molding means that the cranial bones overlap each other, but they can be separated. Whereas grade 3 molding means that the bones overlap each other and they cannot be separated, right? So, but one thing which I want all of you to remember is, if you are getting molding and the progress of labor is slow, that is a very, very important indication of cephalopelvic disproportion, right? So molding along with slow progress of labor is an indication of cephalopelvic disproportion. Please remember that, because now in MCI, the type of questions which you are being asked, they are very, very clinical questions. Right now, I know if it would have been a face-to-face class, you would have asked me, ma'am, what do you mean by slow progress of labor? So all of you know that the slow progress of labor means if dilatation of the cervix is less than 1 centimeter per hour. That is slow progress of labor. So if you are getting a slow progress of labor and molding is present, that should never be taken lightly. That means it is a case of cephalopelvic disproportion, and that means you have to do emergency cesarean section, right? So let's come back to this image. In this image, it's a case of hand prolapse and we are getting cord prolapse. Most probably this was a case of transverse lie and the patient was at home and she was trying to be delivered vaginally. Also remember that if you are getting hand prolapse, if you are getting hand like this and the head of the fetus is also appearing. So if both head and hand, or if head and limb, any limb, it could be hand or it could be feet, anything, they are trying to come out together, that means it's a case of compound presentation. So if you are getting head plus any of the limbs together, you can palpate it. That means it's a case of compound presentation. And in compound presentation also you have to go for cesarean section. The last thing which I want to tell you for this image over here is that, as I told you, in transverse lie, always you have to do a cesarean section. So instead of your question saying transverse lie, they can say it, they can call it as shoulder presentation. In case of transverse lie, it is the shoulder which faces towards the internal os, towards the lower part of the uterus. And because it is the shoulder which faces towards the lower part of the uterus, so whether the question says transverse lie or whether they say shoulder presentation, always and always management is cesarean section, whether the baby is alive or whether the baby is dead. A dead baby with shoulder presentation is called as neglected shoulder presentation. So if they ask you what is the management of neglected shoulder presentation, again, your answer should always be cesarean section, right? The last thing which I want to discuss over here before we move on to the next image is, if they ask you in which condition is the chances of cord prolapse maximum, please remember that maximum chances of cord prolapse are with transverse lie, followed by footling presentation of breech, followed by knee presentation, right? So this is the sequence which you have to remember. First, maximum chances are with transverse lie. If that is not given in the options, then footling presentation of breech. And if that is not given, then knee presentation of breech. And because in transverse lie, footling, and in knee, in all these three conditions, chances of cord prolapse are maximum. That is why cesarean section is done in all these three conditions, right? Okay. Now, look at this image over here and read the question. So the question is saying, this is the condition which was seen in a multi-gravida patient when she came to labor room after a DI tried to deliver her at home. Patient has been in labor for 2 days. Her cervix is 8 centimeters dilated. Vagina is hot and dry. Fetal head is at -3 station. What is the next step in management? Right? So you have to tell what is the next step in management, and your options are apply forceps, start oxytocin, give her rest, emergency cesarean section. So what are you going to do? What is it that you are seeing over here? What are you seeing over here? You are seeing over here in this image that it is the upper part of the uterus, sorry. It is the upper segment of the uterus is this, and this is the lower segment of the uterus, right? You can see that there is a definite groove, there is a definite ring which is palpable between upper uterine segment and lower uterine segment. And that is something which is called as the Bandel's ring, right? So I was talking to you about obstructed labor. Please remember that in obstructed labor, there is a very, very important feature which you have to remember, and that is presence of a Bandel's ring. So during pregnancy, from the third trimester onwards, we see that there is, a very big distinction between the upper uterine segment and lower uterine segment. Lower uterine segment, it is formed by the isthmus of the uterus. Isthmus of the uterus is the lowermost part of the uterus, which is just 0.5 centimeter in a non-pregnant female. And during pregnancy, this 0.5 centimeter of isthmus, it enlarges and it becomes the lower uterine segment. Now, this upper uterine segment and lower uterine segment, both of them, they behave very differently when at the time of labor. So at the time of labor, it is the upper uterine segment which will contract and relax actively, and it will try to push the baby out. And it is the lower uterine segment which passively dilates, right? Now, this patient, she has been in labor for 2 days, right? She's 8 centimeters dilated. Her vagina is hot and dry, and her fetal head is at -3 station, right? Now, first, let me talk to you about this Bandel's ring, and then I'll tell you the significance of this statement -3 station. So Bandel's ring, see, at the time of whenever there is obstructed labor, what happens is the upper uterine segment will contract vigorously and will try to push the baby out, whereas the lower uterine segment will passively dilate. Now, because it is a case of obstructed labor, no matter how much the upper uterine segment tries, the head of the baby will not get delivered, right? So upper uterine segment will try very hard to push the baby out, and as a result, it becomes tonically contracted, very, very thick contracted, right? Whereas the lower uterine segment is dilated. So imagine a uterus in which upper part of the uterus is very tensed, it is very rigid, and it is very thick, and a lower part of the uterus which is just dilated, right, and relaxed. So there will be a distinction which can be seen as well as felt per abdominally, and this is what is Bandel's ring. So the most important point about Bandel's ring is that this ring can be seen as well as felt per abdominally in a case of obstructed labor, right? And just now I told you, whenever a patient comes to you with obstructed labor, the only management which you have to do is you have to do immediately cesarean section. I saw someone of you typing the answer as oxytocin. But in a case of obstructed labor, you are never going to give oxytocin because it is going to lead to rupture of the uterus. The problem is not with uterine contractions. The problem is that there is some obstruction in the passage because of which delivery is not happening. So remember, never are you going to give oxytocin in case of obstructed labor. Neither am I going to give her any rest, because the more I delay my decision, more am I increasing the chances of rupture of the uterus, right? So I am not going to apply forceps. I am not going to start oxytocin. I am not going to give her any rest. I am immediately going to take up the patient for cesarean section, right? Now, Bandel's ring should always be differentiated from one more ring, and that is a Schroeder's ring. Bandel's ring is a pathological ring which is seen in case of obstructed labor. I hope all of you are well versed with this. If not, whatever I'm telling you, these are very, very high yielding points, very important points, and you should make a note of all these points. Although I feel that this video would be uploaded on YouTube as well. I'm not very sure on that, but still please note down whatever I'm telling you. These are the most high yielding points in labor which you have to remember, right? So Bandel's ring is a pathological ring. Schroeder's ring is a physiological ring. Bandel's ring is seen in cases of obstructed labor. Schroeder's ring is seen because you have injudiciously used oxytocin at the time of labor. Bandel's ring is a retraction ring. Schroeder's ring is a constriction ring. Bandel's ring can be seen and felt per abdominally. Schroeder's ring is only felt, and that too per vaginally. So Bandel's ring is seen as well as felt per abdominally. Schroeder's ring is just felt per vaginally, right? Management of Bandel's ring is, because it is seen in cases of obstructed labor, the only management is cesarean section. Management of Schroeder's ring is because you have injudiciously used oxytocin. So you have to just give some time to the patient. The Schroeder's ring will automatically subside. Otherwise, you can give drugs to relax the uterus, right? Okay, so you are saying that you want me to tell more again about the two rings. So let me quickly tell you again about the two rings. If you are noting down, please note down correctly. Bandel's ring is a pathological ring. Schroeder's ring is a physiological ring. Schroeder, that is Schroeder's. Bandel's ring is a retraction ring. Schroeder's ring is a constriction ring. Bandel's ring is seen in case of obstructed labor. Schroeder's ring is seen when you are, I'll take your question, Nidish, a little later. First, let me explain this. Constriction ring is seen when during labor you have used oxytocin injudiciously. So you're going to write it is due to injudicious use of oxytocin. Bandel's ring can be felt and seen per abdominally, whereas Schroeder's ring is felt per vaginally only, right? Bandel's ring, because it is seen in obstructed labor, the only management is cesarean section. Schroeder's ring, because it is due, you have used oxytocin too much. So what you have to do is you just have to relax the uterus for some time and the ring will automatically subside, right? Now, what can be the outcome of Bandel's ring? What problems can happen due to obstructed labor or due to Bandel's ring? The problems which can happen are, it can lead to rupture of the uterus, obstructed labor. And, when there is obstructed labor, it can lead to ischemic injury of the bladder. And that can lead to a vesico-vaginal fistula, VVF. So one very important thing which I want you to understand is, all of us know when we study fistulas in gynae, this is a statement which we mug up, that in developing countries, the most common cause of vesico-vaginal fistula is obstructed labor. What you don't realize is that this vesico-vaginal fistula will never be immediately seen after obstructed labor. Patient is going to come to you after 7 to 10 days with the complaint of leaking from vagina, and that leaking will be because of vesico-vaginal fistula. So if I have to set up a clinical question on obstructed labor, one, I can set it up on Bandel's ring. Second, I can set it up on this fact that a patient in obstructed labor after 7 to 10 days of obstructed labor presented with leaking from vagina, the most probable causes, and I can give you options. So please remember, patient is going to present to you after 7 to 10 days with leaking from vagina, and that the cause is vesico-vaginal fistula, right? So this is what I wanted to tell you about Bandel's ring, and this is how on image they are going to show you a Bandel's ring, that the upper part is tonically contracted uterus and the lower part of the uterus is distended and there is a groove in between, right? Now, let me tell you the significance of this question over here, the -3 station significance over here. So the -3 station significance is, we say that the head of the baby is engaged if station is 0 station. What do you understand by 0 station? When head of the fetus is felt pervaginally at the level of ischial spine. So on pervaginal examination, if head of the baby is at the level of ischial spine, then we say that it is 0 station, right? And head is said to be engaged when head is at 0 station. Now, in this case, the patient's head is at -3. That means the head has not yet engaged, right? And patient is 8 centimeters dilated. So what do you understand by this? This means that the head is unable to enter into the pelvis, right? And that means that it is a case of cephalopelvic disproportion, where the cervix is dilated, it is 8 centimeters, and head is still at -3 station. Head is not yet engaged, although patient is 8 centimeters dilated, right? The time for engagement in a primigravida female is around 38 weeks of pregnancy, but in a multigravida female, it is at the onset of labor. This patient is a multigravida patient, and still she's 8 centimeters dilated, and still her head is at -3 stations. That means the head of the baby is too big to enter into the pelvis. That means it's a case of CPD. Right? And whenever there is a CPD, you have to do a cesarean section, right? So that is a second logic for doing cesarean section. A third logic is, let us rule out why not the other options. Apply forceps. So in modern day obstetrics, forceps are going to be applied when 2 conditions are fulfilled. Number 1, when cervix is fully dilated, then only you apply forceps. And number 2, when station of the fetal head is +2 or below that, right? You're very right, Mohit. Station has to be +2 or below that, then only you can apply forceps. So forceps is out of question. Option B, start oxytocin. Now, already in this patient, what I'm seeing is a Bandel's ring, a case of obstructed labor. I am not going to start oxytocin because it is going to rupture her uterus. Option C, give her rest. In obstructed labor, as it is, we do not give rest because we are concerned about the rupture of uterus. We are concerned about the condition of fetus. Apart from that, giving rest is an option, as I told you, if there is a constriction ring, or it is an option if the latent phase of labor is prolonged. And latent phase of labor lasts only up till 5 centimeters dilatation. Please remember, this is very confusing for all of you. All of you feel that because WHO partogram has to be marked from 4 centimeters, in a WHO partogram, active phase begins at 4 centimeters. So you think that always in clinical questions also you have to say that the active phase begins at 4 centimeters. No. In all clinical questions, you are going to follow the ACOG criteria. ACOG criteria is American College of Obstetrician and Gynecologist criteria, which is that active phase begins from 6 centimeters dilatation. Only if they specifically ask you that what does WHO say, or if they specifically ask you about partogram. Unless and until these two words are there in the question, words like WHO, words like partogram, only in these two situations you are going to say that the active phase begins at 4 centimeters. But other than that, always for all clinical questions, active phase begins at 6 centimeters. This patient is 8 centimeters dilated. So it is the management of prolonged latent phase, which is you have to give rest. In active phase, management is never rest, right? So I have told you how to rule out all these options, because these type of questions are not just image-based questions. They are very clinical questions also. And this time we expect a lot of clinical questions also to come in your MCI exam. Okay. Now the next image is the presenting diameter of the fetal head in the following presentation is. So first what you have to identify is what is the presenting part, and then you have to identify what is the presenting diameter. Now, as you can see, the presentation is cephalic. Why is the presentation cephalic? Because it is the head of the fetus which is lying in the lower part of the uterus, right? But it is the presentation. The engaging diameter or the presenting diameter depends on the presenting part. Now, in case of cephalic presentation, there can be 3 kinds of presenting part. Number 1 presenting part can be vertex. How do you define vertex? Vertex is the part of the head which lies between the posterior fontanelle and anterior fontanelle, right? So whenever the head of the baby is fully flexed like this, and when I am doing a per vaginal examination, my fingers are going to touch the vertex. So in a fully flexed head, the presenting part is vertex, right? So if head is fully flexed, like in image A, in image A, the head is fully flexed and the presenting part is vertex. That is, vertex is the part which lies between the posterior fontanelle and anterior fontanelle. The red color is posterior fontanelle. The blue color is anterior fontanelle. Now, if the head of the baby is deflexed, right, it is not extended, it is not flexed. Now also, when I will do a per vaginal examination, my fingers are going to touch the vertex. So in case of complete flexion and when the head of the baby is deflexed, in both these cases, the presenting part is vertex. But in both these cases, the presenting diameters are different. When the head of the baby is fully flexed, then the presenting diameter is SOB, suboccipitobrachmatic. So when the head of the baby is fully flexed, it appears as if it is crying, it is sobbing. So in a fully flexed head, the engaging diameter or the presenting diameter is SOB, sob, suboccipitobrachmatic, which is 9.5 centimeters, right? But when the head of the baby is deflexed, then the presenting part is vertex, but now the engaging diameter is suboccipitofrontal or occipitofrontal. And suboccipitobrachmatic, that was just 9.5 centimeters, whereas suboccipitofrontal is 10 centimeters and occipitofrontal is 11.5 centimeters. So although the presenting part is vertex, in a deflexed head, the engaging diameters are larger than in a completely flexed head. That is why in a deflexed head, engagement happens a little later. So suppose I just now told you that in a primigravida female, engagement is going to happen at 38 weeks, right? But suppose I have a female, a primigravida female who is in labor and still her head is not engaged. So the most common reason for that would be a deflexed head, right? Because the head is deflexed, it is the larger diameter which has to now pass through the pelvic inlet. So it takes a little larger time, and that is why engagement is delayed, right? Okay, this is when the head is deflexed or completely flexed. Now, what about if the head is partially extended? Now, the moment the head is slightly extended, what is going to happen? Now, when I'm going to do a pervaginal examination, my fingers are going to touch the brow area. How do you define a brow area? Brow area is the part of the head which lies between anterior fontanelle and root of the nose, along with the supraorbital ridges. So this part is your brow area. So when the head is slightly extended, it is brow which is the presenting part. And whenever brow is the presenting part, the presenting diameter is mento-vertical diameter. But so please remember that mento-vertical diameter is 14 centimeters. It is the largest AP diameter, right? And because cervix, when it is fully dilated, it is 10 centimeters. Whereas mento-vertical diameter is 14 centimeters. So obviously a 14 centimeter diameter can never pass through the cervix. And that is why whenever you have brow presentation, you always have to do a cesarean section, right? Now, if head of the baby is completely extended like this, now, in this case, when I am going to do a pervaginal examinations, my fingers are going to touch the face area. How do you define face area? It is the part of the skull which lies between root of the nose and chin, right? So this area is the face area. Now, in case of face area, the engaging diameters are either submento-vertical diameter or submento-brachmatic diameter, right? So what you have to do whenever you get an image like this, you have to see how is the position of the neck. Is the neck flexed? Is the neck deflexed? Is the neck slightly extended, or is the neck fully extended? In this image, what we are seeing is that the neck is slightly extended. Now, because the neck is slightly extended, that is why it means it's a case of brow presentation. And that means the diameter which is going to engage is mento-vertical diameter. Also, if you mark an arrow from here, so if I mark an arrow, if I do a pervaginal examination and I mark an arrow from here, my fingers are touching the brow area, right? But the better way is you have to see the extension of the neck, because the neck is partially extended. Now you're going to say, ma'am, how have you said it is partially extended? Why not fully extended? Because if neck would have been fully extended, the occiput area would have touched the back, right? Here, the occiput is not touching the back. That is why I'm saying it is partially extended. Clear to all of you? Okay. So they can show you any of these images and they can ask you the presenting diameter. So these images are equally important. Now you have to identify the fetal, it's not presentation, sorry, it's fetal position which you have to identify in this image. Whenever you have to identify fetal position, you have to first see, it is a cephalic presentation. In cephalic presentation, the denominator is the occiput. Denominator is the most prominent bony point, right? So in cephalic presentation, it is the occiput which is the denominator. So that means occiput is lying somewhere here, right? Now, occiput is lying here. That means it is lying anteriorly, right? So I know that this is either, this has to be occipito-anterior. It could be left occipito-anterior or it could be right occipito-anterior. Now, if I have to decide this, the easiest thing what you have to remember is, if in the image occiput is pointing towards your left side, it will be mother's right side, right? So it's a mirror image. So if it is your left side, it will be patient's right side. So in this image, it is your left side. So it is mother's right side. So this is right occipito-anterior position. So always first identify where the occiput is, whether it is anterior or whether it is posterior. In this case, occiput is anterior. Then see whether the occiput is towards your left-hand side or towards your right-hand side. Whatever it is towards your side, it will be the reverse in the mother. So it is towards my left hand, towards your left hand. So in mother, it will be towards right hand. Clear to all of you? So the answer over here is right occipito-anterior position. Image like this is very easy if you get, but same image can be made a little complicated by giving an image like this. Now, whenever you get an image like this, again, you have to see where is the occiput lying. And in order to identify where the occiput is lying, you should understand the anatomy of the fetal skull. In fetal skull, you have the frontal bones, right? Then you have the frontal suture. Then you have the parietal bones. This is the coronal suture. Then you have sagittal suture. And you have the occipital bone, right? Now, this gap between suture lines, that is what is fontanelle. So this fontanelle over here, which is a diamond-shaped fontanelle, is anterior fontanelle. And this fontanelle over here, which is a triangular fontanelle, is posterior fontanelle. This is coronal suture, this is sagittal suture, this is lambdoid suture, right? So you can see over here that it is the triangular fontanelle which is near the occiput, right? And the triangular fontanelle is the posterior fontanelle. It is the posterior fontanelle which is lying close to the occipital bone. So if you are getting an image like this, which is there on your screens just now, what you have to look at is the position of the triangular fontanelle, because the triangular fontanelle represents posterior fontanelle, and wherever is the posterior fontanelle, there is the occipital bone. So over here, what you are seeing, this is the triangular fontanelle, right? Now this triangular fontanelle, where is it? Is it towards anterior side or is it towards posterior side, or is it exactly in the middle of anterior and posterior? I can see that this triangle is exactly in the center. So it means it is occipito-transverse position, right? It is neither anterior nor posterior, right? So it is exactly in the center. So it is neither towards the pubic symphysis nor it is towards sacral promontory. It's midway. So it is occipito-transverse. Now, this triangular fontanelle, it is towards your left-hand side or towards your right-hand side. As you can see in the image, it is towards your right-hand side. So if it is towards your right-hand side, mothers, it will be the opposite. So because it is towards your right-hand side, in the mother, it will be left. So the answer is LOT. So this image is representing LOT, left occipito-transverse position, right? Have you understood? Whatever is the image showing towards your side, it is the opposite in the mother always, right? Now, let's go to the next question. In the next question, you have to identify the grip which is shown in the image, and you have to tell what the yellow line indicates, right? So first, look at this image. Identify the grip. Tell me whether it is Leopold's first maneuver, second maneuver, third maneuver, or fourth maneuver. As you can see here, there is a single hand, and this single hand is near the pelvic area, right? So this is Leopold's third maneuver, or the Pollock grip, right? So quickly look at the images of Leopold's maneuvers. This image over here is Leopold's first maneuver. In Leopold's first maneuver, you palpate the fundal area of the uterus with both your hands, and your face is towards the face of the patient, right? Then from the fundal area, you move your hands towards laterally, and now you are going to palpate the sides of the uterus. Now, when you are palpating the sides of the uterus, that is Leopold's second maneuver, and that is called as the lateral grip, or that is called as the umbilical grip. Still, your face is towards the face of the patient. Now, gradually, you are going to come down, and you are going to just use your one hand. The ulnar border of your right hand should be above the pubic symphysis. Make a cup and try to feel what you are feeling just above the pubic symphysis. This you are doing again facing the face of the patient with a single hand. This is what is Leopold's third maneuver, which is called as the Pollock grip, right? So first, second, and third Leopold's maneuver, they are done facing the face of the patient. First maneuver, which is the fundal grip, is going to tell you what is the lie and what is the presentation. If you are feeling anything in the first maneuver, that means it's a longitudinal lie, because in transverse lie, the fundal grip will be empty. You will feel nothing, right? So that is how it tells you about the lie. Then it tells you about presentation. How does first grip tell you about presentation? Most of the times, the presentation is cephalic. And obviously, if it's a cephalic presentation, head will be down, and it is the buttocks which will be towards the fundus of the uterus. And the feel of the buttocks is broad, soft, irregular, nodular. So if you are getting broad, soft, irregular, nodular feel, that means you are feeling the buttocks, and that means it is cephalic presentation, right? Now move your hands towards the sides of the uterus. Stabilize the uterus with one hand and try to palpate with the other hand. Now, wherever you are feeling a smooth feeling, a board-like feeling, and curved feeling. So if you are getting smooth, so this is what I'm describing. I'm describing the back. So if you are feeling smooth, a smooth, curved, board-like rigidity, that means you are feeling the back. And if you are getting multiple nobular, irregular structures, that means you are feeling the limbs. Now, wherever is the back of the baby, that is the position of the baby. So if the back of the baby is on the left side, so that means the position is either LOT or LOA or LOP. If the back is on the right side, then that means the position of the baby is either ROT or ROA or ROP. In other words, second Leopold maneuver tells you about the position of the fetus, right? Then comes the third maneuver, which is the Pollock grip. Now, with my one hand, right hand, I will feel what I am getting just above the pubic symphysis. That is in the lower part of the uterus. Most of the times you are going to get a cephalic presentation. So the feel will be something which is globular, that is round, hard and smooth. So if you are getting hard, firm, globular feeling, that means you are feeling the head, right? Now, once you have felt that the head is there, now what you are going to do, like in the line it is shown with the yellow arrow, try to move the head and see whether head can be freely moved or not. If head can be freely moved, that means head is ballotable, right? And if head is ballotable, that means head has not yet entered the pelvis. So I want all of you to write this line, that if head is ballotable, it means head has not entered the pelvis. Second line you are going to write, if head is not ballotable, it means head has entered the pelvis. Please write in red, it does not mean that the head is engaged, right? There is a lot of difference between head entering the pelvis and head being engaged. So first, understand that difference. Look over here in this image. Now, the red arrow is showing the moment head will cross this red arrow, that means head has entered the pelvis. And just now I told you engagement means that the head of the baby should be at 0 station. That means engagement would mean that the head is at this level. Then I am going to say that the head is engaged. So head entering the pelvis and head being engaged are two very different things. The moment head enters the pelvis, you say that yes, head is entered and now head will not be ballotable. That in scientific, in medical term, we say the head is fixed. The moment head enters the pelvis, we say that the head is fixed now. But when the largest transverse diameter has crossed the pelvic inlet, right? That means head has come deeper down. Then we say that the head is engaged. So on per vaginal examination, head is said to be engaged only if head is at 0 station. Per abdominally, how am I going to know that the head is engaged? Per abdominally, see, normally, if head has not entered the pelvis, if head is above the pelvis just now, with my entire 4 fingers and thumb, I will be able to feel the head, right? So entire head will be palpable through my 4 fingers and thumb. The moment head enters the pelvis, now my all 4 fingers and thumb will not be required to palpate the head. Now only 4 fingers are sufficient, right? So that means now 4/5 of the head is palpable. So when 4/5 of the head is palpable, that means head has entered the pelvis. Now head will go a little more down. Now only 3 fingers will be needed. That means 3/5 of the head is palpable. Now head will go a little more down. Now head, only my 2 fingers are sufficient to palpate the head. That means 2/5 of the head is palpable per abdominally. The moment 2/5 of the head is palpable per abdominally or less than 2/5 is palpable per abdominally, then we say the head is engaged. So for engagement, there are 2 criteria: per abdominal criteria or per vaginal criteria. Per abdominal criteria says when 2/5 or less than 2/5 of the head is palpable per abdominally, then we say that the head is engaged. And per vaginal criteria is that when head is at 0 station per vaginally, that means head is at the level of ischial spine, then we say that the head is engaged, right? So please remember, head entering the pelvis and head being engaged are 2 different things. First, head will enter and then it will get engaged. So Leopold's third maneuver tells you only whether the head has entered the pelvis or not. It doesn't tell you that the head is engaged or not. Is that clear to all of you? So that is what is Leopold's third maneuver telling you. It is telling you about presentation, plus it is telling you whether head is floating or fixed. Floating means head has not entered the pelvis. Fixed means head has entered the pelvis. I haven't used the terms engaged here. Please be very careful, right? Now, the last maneuver is done while you are facing the feet of the patient. And now whatever you did in third maneuver, you are going to confirm it in fourth maneuver, which is called as the deep pelvic grip. You are going to keep your both hands parallel to inguinal ligament, and you are going to again reach above the pubic symphysis, and you'll try to palpate what part you are feeling. Again, if you are feeling something which is globular, hard, firm, you say, I'm feeling the head. That means you've confirmed the finding of the third maneuver. Plus, now look again over here. If head of the baby has not yet entered the pelvis, when I will do Lupol's fourth maneuver, my both fingers are going to converge below the head. So if your fingers can converge below the head, that means head has not entered the pelvis. The moment head enters the pelvis, now my fingers cannot converge below the presenting part and my fingers will diverge. So if your fingers can converge below the presenting part, that means the head has not entered the pelvis. If your fingers cannot, if your fingers are diverging, that means the head has entered the pelvis. So it is again confirming what was told to you in the third grip. The new thing which fourth maneuver tells you is about the attitude of the fetus. Attitude means how is the relationship of different parts with each other. That means whether the head is flexed, deflexed, or extended. This can be known by the Lupol's fourth maneuver, right? And since this is just a webinar, I cannot tell you everything here. So this is something which needs a little more discussion. And if you have subscribed to Marrow, you will be able to see this discussion in my video there, that how you come to know whether the head of the baby is flexed, deflexed, or whether it is extended, right? Okay, so please tell. Now see over here, the options were, you had to identify the grip in this image and you had to tell what the yellow line is telling you. The options were, it is Pollock grip and the yellow line shows engagement of fetal head. Option B, it is deep pelvic grip and the yellow line shows engagement of fetal head. Option C, it is Pollock grip and yellow line shows ballotment. And option D, deep pelvic grip and yellow line shows ballotment. So just let me check what you people have answered. Yes, all of you have answered it correctly, and it is option C. So that means you've understood this concept. Okay. Yeah, now you can also be given images like these, and I'm sure you will now be able to see, tell what this is showing. This is showing that the head is palpated by all four fingers and thumb. That means the entire head is above the pubic symphysis. That means head has not yet entered the pelvis. So 5 by 5 of the head is palpable per abdominally. If you get an image like this, this means only 2/5 of the head is above the pubic symphysis. That means head is engaged, right? So images like these can also be shown to you. Now, you have to identify the diameter being measured in the video clip. So I have this video clip over here. Look at it carefully and tell which diameter is being measured. Have you all seen? I'm playing it again. Look at it carefully. Okay, seen? So now let me go back and tell you the options. Obstetric conjugate, diagonal conjugate, interischial diameter, intertuberous diameter. So what was being measured? What you saw was a diameter which was being measured like this. So your fingers are touching the lower border of pubic symphysis and they are going up till the sacral promontory. So what is being measured? It is the diagonal conjugate which is being measured, right? So answer should be B, and I think all of you have marked it as B. Yes, all of you are saying it is B. So this is diagonal conjugate which was being measured. So all of you know that there are 3 AP diameters of the inlet. This is the image of the video clip which was shown to you. Here, what you are seeing is that your fingers are touching the lower border of the pubic symphysis and they are going up till the sacral promontory, right? So in AP diameter of the inlet, the only diameter which can be measured clinically is diagonal conjugate. Diagonal conjugate is the distance between the lower border of pubic symphysis and up till sacral promontory, the red color one. The value of diagonal conjugate is 12 centimeters. Obstetric conjugate is from middle of pubic symphysis. So obviously, if it is from the middle of pubic symphysis, you cannot measure it clinically, right? And it is going up till the sacral promontory. Value of obstetrical conjugate is between 10 to 10.5 centimeters. And from upper border of pubic symphysis going up till the sacral promontory is true conjugate, right? True conjugate is 11 centimeters. So from upper border of pubic symphysis up till sacral promontory, true conjugate. From middle of pubic symphysis up till sacral promontory, obstetrical conjugate. And from lower border of pubic symphysis going up till sacral promontory is diagonal conjugate. And obviously, it is only the diagonal conjugate which can be measured clinically, right? Now, whenever you measure diagonal conjugate, from diagonal conjugate, you have to subtract 1.5 to 2 centimeters to get the value of obstetrical conjugate. Why we need the value of obstetrical conjugate? Because obstetrical conjugate is the smallest AP diameter amongst these 3. So if head of the fetus can pass through obstetrical conjugate, obviously it can pass through the other 2 as well. Because true conjugate is 11 centimeters, obstetrical is 10 to 10.5, and diagonal is 12. So I am not bothered about diagonal conjugate because it is the largest diameter. I am worried about obstetrical conjugate because if obstetrical conjugate is less than 10 centimeters, then that means the inlet of the pelvis is contracted, and such a pelvis will be called as contracted pelvis. So the minimum value which you need for a normal vaginal delivery is that the obstetrical conjugate should be 10 centimeters. Now, the diameter which can be measured is diagonal conjugate, and contracted pelvis is defined in terms of obstetrical conjugate. So that is why whenever we have to assess the pelvis, I will assess the diagonal conjugate. I will measure the diagonal conjugate. Whatever measurements are coming, from that, I will subtract 1.5 to 2 centimeters to get the value of obstetrical conjugate. And if obstetrical conjugate comes out to be less than 10 centimeters, then that means it's a contracted pelvis, right? Is that clear to all of you? Normally, the value of diagonal conjugate is 12 centimeters. And when the value of diagonal conjugate is 12 centimeters, believe me, it will be very difficult for you to touch the sacral promontory of the patient. If you can touch the sacral promontory of the patient, that means diagonal conjugate is less than 12 centimeters. It is not 12 centimeters. If you are unable to touch the sacral promontory, then you shouldn't worry at all, because then diagonal conjugate definitely is 12 centimeters, right? Then I am not worried at all. Only if I can touch the sacral promontory, I am worried. In that case, you should measure the diagonal conjugate with the help of a measuring tape. Put a mark wherever you are feeling the diagonal conjugate on your finger and measure that. Once you have measured that, subtract 1.5 to 2 centimeters from it to get the value of obstetrical conjugate. And if the value of obstetrical conjugate comes less than 10 centimeters, tell your patient that I'm going to take you up for cesarean section whenever you go in labor, right? Clinical pelvimetry, that's very important in all primary gravida patients. And clinical pelvimetry, it should be done between 37 to 38 weeks in a primary gravida patient. In a multigravida patient, you should never, in a multigravida patient, you are not going to do clinical pelvimetry beforehand, right? Because obviously, if she has undergone vaginal delivery, I know that her pelvis is adequate. But at the onset of labor, I am going to check her pelvis, because now I am going to check her pelvis for cephalopelvic disproportion, right? So in a primigravida patient, clinical pelvimetry has to be done before the onset of labor, around 37, 38 weeks. In a multigravida patient, it has to be done at the onset of labor, right? Now, when we are talking about clinical pelvimetry, this is how inlet, contracted inlet is detected. Now, not only is the inlet important, the cavity and the outlet is equally important. So I have an image-based question for you here as well. Identify the diameter being measured in the figure. Which diameter is being measured? Tell me. Option A, transverse diameter of the inlet. Option B, intertrochanteric diameter. Option C, interischial diameter. Option D, intertuberous diameter. What is being measured here? Oh, that's wonderful. All of you are so intelligent. It's the intertuberous diameter, and all of you are telling the answer correctly. Let me quickly tell you how intertuberous diameter is measured. See, outlet, always remember, inlet lies at the level of pelvic brim, right? Mid cavity, or the mid pelvis, the cavity or the mid pelvis lie at the level of ischial spine, right? And outlet lies at the level of ischial tuberosity, right? So your inlet is at the level of brim, then mid pelvis or cavity is at the level of ischial spine, and outlet is at the level of the ischial tuberosity, right? Now, apart from inlet, outlet is very important. And in outlet, the most important diameter is the transverse diameter of the outlet, which is the distance between the two ischial tuberosities, right? Normally, this intertuberous diameter, the distance between the two ischial tuberosities, is 11 centimeters. If this diameter becomes less than 8 centimeters, you say that the outlet is contracted. So normally your intertuberous diameter is 11. If it becomes less than 8, you say that the outlet is contracted, right? Now, clinically, how am I going to know whether the outlet is contracted? I am going to take my hand and these 4 knuckles, right? So the 4 knuckles, I'm going to try to introduce them between the ischial tuberosity of the patient, right? If my 4 knuckles can easily go in between the two ischial tuberosities of the patient, that means her outlet is normal. That means intertuberous diameter is normal. If you cannot introduce your 4 knuckles between the two ischial tuberosities, then that means the outlet is contracted. So many times when you will go through in the labor room, when you will go through the pelvic assessment, you will see if the outlet is normal, they will write it as outlet normal. But if the outlet is contracted, they will write outlet is 4K tight. So 4 knuckles are able to go, but tightly, or outlet is corresponding to 3K. So that means 3 knuckles, only 3 knuckles can be introduced between the ischial tuberosities. And that is what was being shown here. Between the two ischial tuberosities, we were trying to introduce our knuckles, and we were trying to see whether all 4 can be inserted or not, right? That is how you come to know whether the outlet is normal or not. Now, when it comes to mid pelvis or cavity, then comes a very, very important diameter, and that is the diameter between the two ischial spines, right? Which is called as the interischial diameter, or the bispinous diameter, or the interspinous diameter, right? Now, normally the interischial diameter or the bispinous diameter is 10 centimeters, and this is the most important diameter in the entire pelvis, right? Because no diameter is smaller than this. So it's the most important diameter. And if this diameter becomes less than 8 centimeters, then we say that the mid pelvis or the cavity is contracted. Now, this is theoretical. Practically, how am I going to know whether the interischial diameter is normal or not? One is you should try to feel the ischial spines of the patient. right? Normally, in a gynecoid pelvis or in any pelvis, ischial spines are not prominent except in android pelvis. Android pelvis is a male-shaped pelvis. In android pelvis, the ischial spines are prominent, right? Number two, what I'm going to do is I am going to introduce my both these fingers of one hand, and simultaneously I'm going to try to touch both the ischial spines. So if you can touch both the ischial spines simultaneously with the two fingers of same hand, then that means here I am unable to touch. I am finding it a lot of difficulty to touch both of them simultaneously, right? I am not able to touch. You can see my finger is not touching. Now, if you can touch both the ischial spines simultaneously with two fingers of your same hand, that means the ischial spine, the interischial diameter is small. That means the mid pelvis or the cavity is contracted, right? So this is how clinically we come to know how is the pelvis. Apart from that, another very important thing which you have to check is this subpubic angle, right? You have to feel this subpubic angle. If subpubic angle is obtuse, that means it's a female pelvis, it's a gynecoid pelvis. If this subpubic angle is acute, that means it's a male pelvis or android pelvis. And whether it is a contracted inlet, whether it is a contracted mid pelvis, or whether it is a contracted outlet, always and always management would be cesarean section. When we say that there is a gynecoid pelvis or android pelvis or anthropoid pelvis, this classification was given by Cadwell and Mohoy. Name is important and features of such pelvis are important for you to know, right? Now, next question is identify the maneuver which is being performed. Option A, McRoberts maneuver. Option B, Leupold maneuver. Option C, Pinard's maneuver. Option D, modified Ritgen maneuver. Tell which one is being performed. Let me check what people are writing. So you are confused between two. Oh, someone is saying A, someone is saying C, someone D. So that means you don't know this maneuver. I can make out from your answers. This is a modified Ritgen maneuver. This maneuver is done in a normal vaginal delivery to help in assisting the delivery of the head. As you know, that WHO says that if you have to prevent perineal tear, you don't have to give episiotomy in all cases. That is not recommended by WHO. WHO says that just because you want to prevent a perineal tear, you don't have to give episiotomy. What WHO recommends is you have to support the perineum with one hand and deliver the head of the fetus slowly with your other hand, right? So here also what you are seeing is one hand is on the perineum and slowly the head of the baby is being delivered with the other hand. Do not go into any other details. This is a very easy way of explaining this maneuver, right? So just remember this, that if you are seeing that one hand is on the perineum and other hand is trying to deliver the head of the baby slowly, it is a modified Ritgen maneuver, which is done to deliver the head of the baby during normal vaginal delivery, right? This is all what you have to remember about this image. The other thing which you have to remember is WHO does not recommend giving episiotomy to prevent perineal tear. That's a very, very important line on which many MCQs have been asked, right? Now, that also tells me that you don't know the maneuvers, because otherwise you could have ruled out. Even if you don't know that it is a modified Ritgen maneuver, if you would have known what is a McRobert maneuver, what is Leupold's maneuvers, and how did you answer Leupold maneuver? Someone said option B. Is it a Leupold maneuver? Leupold maneuver is done per abdominally when the baby is not yet delivered in an antenatal patient, right? So if you would have known McRobert and Pinard, then by exclusion, you would have told that the answer is modified Ritgen. So I'm going to take up all the maneuvers quickly with you. Here, I'm going to show you a video and you have to identify the maneuver which is being done. So I'm playing the video for you. Right? Replaying it so that you see it properly. Okay. Just let me look at the chat. What are the answers which you have given? Okay. You start giving correct answers and in between I start getting all wrong answers. We start with the correct answer and then all of a sudden, I don't know what happens. One of you gives a wrong answer and everyone follows that wrong answer. Okay. So that first of all, what you saw here was that the legs of the baby are delivered first and the head is still inside, right? That means it's a maneuver where breech delivery is happening. So it means you have to think about maneuvers of breech delivery. And that too, what you are seeing over here is that the legs are delivered. You can see over here that shoulders are delivered. I'll show you again. Legs are delivered, right? And you are trying to deliver the head of the baby, right? So this is a maneuver which is related to delivery of the head of the baby. So for delivery of head of the baby, there are two maneuvers, Burn-Marshall technique and Morrisseau-Smiley-Wheat maneuver. I am going to start the breech delivery from the beginning. That means from the legs. So when you have to deliver the buttocks of the baby, right? Most of the times, if the buttocks are flexed, it is very easy to deliver. I'm going to give pressure over here in the groin area and the leg. Oh, sorry, my baby is ulta. Wait, right. So I am going to give pressure in the groin area and the leg would deliver. This is called as groin traction. Groin traction is used for delivery of the buttocks when the legs of the baby are flexed, right? When the legs are flexed, you simply have to give traction and the groin traction, give a little bit of traction and the leg gets delivered. But if the legs of the baby are extended like this, like it is called as frank breech. In this case, I cannot give groin traction. The leg will not come out like this, right? There is not that much of space in the pelvis. So in this case, I'm going to take my fingers up till the popliteal fossa. I will give a little bit of pressure, hold the feet of the baby and deliver the leg. Take your fingers up till popliteal fossa, give a little bit of pressure, hold the feet of the baby and deliver. Please remember P for popliteal fossa, P for Pinard maneuver, right? So for delivery of legs, there are two maneuvers, groin traction, image is shown to you for the groin traction, and Pinard's maneuver. So if you are seeing that the fingers are going up till the popliteal fossa and the legs are being brought down, that means it's a Pinard maneuver, right? Now, once the legs are delivered, now I have to deliver the shoulder, right? Now, if the shoulder has to be delivered, simply what you have to do is you have to hold the back of the baby like this and rotate the shoulders, right? So that the shoulders come in antero-posterior direction. Now, once the shoulders are going to come in antero-posterior direction, they will automatically deliver. This is called as Lovset's maneuver. So if you see an image where you are holding the back of the baby like this, and it is being rotated, it means it's Lovset's maneuver for the delivery of the shoulder. Right? Then, so first the legs or the buttocks got delivered, then the shoulder. Now comes the head. Now, because in breech, head is the last part to be delivered, so it is called as after coming head of breech. Now, what I'm going to do is, I am going to let the baby hang by its own weight. So I will let the baby hang by its own weight like this, right? Once the occipital protuberance is visible to me, I am going to hold the legs of the baby and I am going to lift it towards the mother's abdomen. I am holding the head just now. That is why it is not getting delivered, so that you see. Let the baby hang by its own weight. hold the feet of the baby and take it towards mother's abdomen, and the head of the baby would get delivered. This is called as Byrne-Marshall technique. And this is what you saw in the video. I'll play the video again so that you can appreciate it again. See, the feet of the baby are held and it is taken towards the mother's abdomen and the head gets delivered. This is what is Byrne-Marshall technique. The other way of delivering the head is by Morrisseau-Smiley-Wheat method. In Morrisseau-Smiley-Wheat method, you are going to again deliver the head. Now what you have to do is, with your one hand, you have to give traction to the shoulder, right? Your one hand has to give traction to the shoulder, right? And your other hand has to be on the cheek of the baby, right? So one hand is going to go inside the vagina on the cheek of the baby, other hand is going to be on the shoulder, and you are going to flex the head of the baby, right? Because in case of breech, it is that head is delivered by the movement of flexion. So what I'm going to do is, I don't have a helper here, so I am going to put my, you can see, my fingers are on the cheek of the baby. My hand is on the shoulder. I'm going to flex and I'm going to deliver. Because the pelvis is there, no one is there to help me. It gets delivered, right? So if you have seen the marrow videos, you would have seen that it gets delivered very easily. This is called as Morrisseau-Smiley-Wheat technique, or this is called as malar flexion and shoulder traction. So the image will be something like this, where the fingers are there on the cheek and on the shoulder. So this is Morrisseau-Smiley-Wheat technique. So that the question which I showed you, that question was of Byrne-Marshall technique. These are all the maneuvers which are used in breech, right, for delivery of the various parts. This is another image showing Morrisseau-Smiley-Wheat technique, or malar flexion shoulder traction. Now, the last way of delivering the head in breech is by using a forceps, which is called as Piper's forceps, right? And that's the best method. So you have to know how to identify different types of forceps. Now, there are 3 forceps which you have to know for identification in image-based question. These 3 forceps are Piper's forceps, Keelant forceps, and Wrigley's forceps. There are 2 long forceps and 1 short forceps. The 2 long forceps which you have to know are Piper's forceps and Keelant forceps. So how are you going to differentiate between these 2 forceps? Image A is a Piper forceps. In Piper's forceps, so normally when you look at a forceps, normally in a forceps, what you get is, you will get a curve which is inside. This curve which is inside, this is the cephalic curve, and a curve which is outside. This outside curve is the pelvic curve, right? So the one which comes inside is the cephalic curve, and the curve which comes outside is the pelvic curve. There is only one forceps in which you get another curve like this. This curve, this bend which you are seeing, is seen only in Piper's forceps. So if you see a forceps image where you are getting a bend like this, that means it's a Piper's forceps. A Piper's forceps is a long forceps, and it has a perineal curve, right? So apart from cephalic curve and the pelvic curve, it has one more curve, which is the perineal curve. This curve, or this is raised thing which you are getting, this is seen only and only in Piper's forceps. And Piper's forceps is used for delivery of after coming head of breech, right? Now, if you get a long forceps which is straight, and it does not have any perineal curve. That means it's a Keeland forceps. Keeland forceps. The identification mark for a Keeland forceps is this is the only forceps which has got a sliding lock. All the other forceps have this kind of a lock, which is English lock. Right? This is the only forceps which has got a sliding lock. Right? So this is a forceps over here. Most of the forceps have got a lock like this kind of a lock. Right? This lock. Right? This lock which you are seeing over here is English lock. In an English lock, it is mandatory that the left forceps has to be introduced first, then only the forceps will close, right? But this is the only forceps which has got a lock like this. This is a sliding lock, and this is the only forceps where you will get this lock. This is Keeland's forceps. Keeland forceps, another unique thing about Keeland forceps is normally forceps cannot rotate the head of the baby. Keeland forceps can rotate the head of the baby. So it is a rotational forceps. It is a rotational forceps, although it is outdated. Now it is no longer used. So I hope you will understand how to identify Piper's forceps and how to identify Keeland forceps. Okay. The third forceps which they may show you. So I have again showed you over here. This is a sliding lock, right? The rest, all the other forceps will have a lock like this, which is an English lock. The third forceps which they may show you is a very small forceps. The small forceps, if you get an image like this is Wrigley's forceps. It's a very short forceps, a very small forceps, and it is an outlet forceps. Right? So for image-based questions, these are the only three forceps which they can show you and they can ask you to identify, right? Now let's look at vacuum over here. This over here, what you are seeing is a vacuum cup. This is a sialistic vacuum cup. Sialistic vacuum cups are the ones which are used these days. Metallic cups are no longer used. And in a vacuum, the initial pressure is 0.2 kg per meter square. Finally, the maximum pressure is 0.8 kgs per meter square, right? Whenever you are applying vacuum, you have to be very sure that the center of the cup lies at the flexion point. Now, if they can ask you, what is flexion point? Flexion point is a point which lies 3 centimeters anterior to the posterior fontanelle and 6 centimeters posterior to the anterior fontanelle, right? 3 centimeters anterior to posterior fontanelle, 6 centimeters posterior to anterior fontanelle. This point over here is called as flexion point. The center of the cup should lie at the flexion point, right? Why have I showed you this image is because I don't expect them to give you this image. This is very simple. They may give you an image like this. This is a portable vacuum cup, which is called as Omni cup, right? So this, see, normally this vacuum cup has to be attached to a suction machine and then pressure would be generated, right? And this is too bulky to carry from one place to another place. This will be there in the labor room. You cannot carry it anywhere. These days we have Omni cups. Omni cups, they have got inbuilt pump to create the vacuum. They are very small in size. They are disposable cups and they can, they are portable, right? So this is again the latest variety of vacuum which we have, that is an Omni cup, right? They may show you this image. Now, again, what you have to see this video over here and you have to identify which maneuver is being done now. Again, I'll just look at this maneuver and I'll play it again so that you see it properly. So what we are seeing is that the head is delivered. So 100% it is not a maneuver of breech, right? Head is being delivered, head has been delivered. Now, Look what has happened. The legs of the female are flexed and suprapubic pressure is being given, right? So the legs of the female are flexed and suprapubic pressure is being given. I'm sure you would have understood even without options what maneuver is this, right? So if you have understood what maneuver is this, now you have to answer questions related to that maneuver. So first, quickly tell me what maneuver was this? This is a Mac-Roberts maneuver. Very right. So all of the following statements are true except option A, this maneuver is done in shoulder dystocia. Yes. Concurrent fundal pressure should be given while doing this maneuver. Yes. When you are doing Mac-Roberts maneuver, you have to give a concurrent fundal pressure. Option C, it can lead to injury to lateral cutaneous nerve of the thigh. Yes. It can lead to injury to lateral cutaneous nerve of the thigh. It is the first step in the maneuver is flexion of thigh, right? So actually all the statements in this are correct, right? It is all statements are correct. I had to put one incorrect statement, but I have put all correct statement. That's my mistake. All the statements are correct, right? So this was a question which I had made up. I had to put up one incorrect statement. I'm sorry. I have put up all correct statements over here, right? So let us quickly see how do you manage shoulder dystocia. I want all of you to write this sequence because this sequence is very important. So the sequence in which shoulder dystocia has to be managed, that is HELPER. It is, you can remember it by an acronym HELPER, where H stands for, sorry. Option B is incorrect. It is saying concurrent fundal pressure should be given. That is incorrect. Concurrent suprapubic pressure should be given. It is not fundal pressure which has to be given. I'm sorry. I also didn't read the question properly. So please, in your exams, you also read your question very properly. Here, the question is saying concurrent fundal pressure should be given. It is not fundal pressure which has to be given. It is suprapubic pressure which has to be given, right? You can see over here. So please do not go by what I said. Please remember the answer is B, right? You don't have to give fundal pressure. You have to give suprapubic pressure, right? So H stands for, in shoulder dystocia, H stands for, you have to call for help. E stands for episiotomy should be given. Do not give fundal pressure. L stands for a leg maneuver. That is the Mac-Roberts maneuver. That's the first maneuver which you do. In this leg maneuver or the Mac-Roberts maneuver, you flex the thighs of the patient against her abdomen and then abduct them. Right? So I am going to flex the thighs of the patient against her abdomen. I'm going to tell two helpers to do this, and I'm going to abduct her thighs. And simultaneously, I'm going to give suprapubic pressure. You never give fundal pressure in case of Mac-Roberts maneuver, right? So P stands for give suprapubic pressure along with it. E stands for, now if this fails, then what I'm going to do is I'm going to take my hand inside and I am going to rotate the shoulders. So E stands for entering maneuvers, right? Which are the Wood's corkscrew maneuvers and Rubin's maneuver. You don't need to know any details, just the names of these maneuvers. Then suppose this also fails, then comes, I am trying to deliver the posterior arm. So E was for, you have to enter your hand and try to rotate the shoulders. If simply by rotating the shoulders get delivered, that's fine. And these maneuvers are called as Wood's corkscrew maneuver or Rubin maneuver. If that fails because your hand is still inside, try to deliver the posterior arm, right? So R is removal of posterior arm. If that also fails, then the last R is you have to roll the patient on all four limbs. That is called as Gaskin's all four maneuver. And then you have to try to deliver the shoulders, right? So these are the steps which you have to do if you come across a patient of shoulder dystocia. If all these helper fails, then the last resort which you have is you have to push the head back inside the uterus and you have to do the cesarean section, which is called as Zavanelli's maneuver. So not only is the management of shoulder dystocia important, the sequence in which it occurs is also very important, right? Now, in shoulder dystocia, a very important thing which you have to remember is that the head will deliver, but shoulders will get stuck. And so the shoulders will try to pull the head inside, right? And so, like, it is the turtle which is moving inside its shell. So this is called as turtle sign. So if someone asks you, turtle sign is seen in case of shoulder dystocia. Now, which is the first maneuver which you do in shoulder dystocia? McRoberts maneuver. Which is the best maneuver? McRoberts maneuver. Fundal pressure is contraindicated. Suprapubic pressure has to be given in shoulder dystocia. While you are doing McRoberts maneuver, you have to concurrently give suprapubic pressure, and you may injure the lateral cutaneous nerve of the thigh, right? Okay. Now, what is the most common maternal complication of shoulder dystocia? PPH. And most common fetal complication of shoulder dystocia? Brachial plexus injury, right? Now, next question. This is based on partogram. Preeti, a G2P1, was admitted. She came to labor room at 10 a.m. in the morning and was delivered vaginally at 8 p.m. by JR3 on duty. Her partogram was plotted as shown below. The JR3 goes to perform delivery of the next patient when the consultant arrives and asks the JR1 about the detail of Preeti's delivery. The following statement told by JR1 was incorrect. So this question is based on how you read a partogram, right? So option A is saying at the time of admission, Preeti was 4 centimeters dilated. Option B, she was having mild uterine contractions at the time of admission. Option C, progress of the labor was normal. Option D, artificial rupture of membrane was done at around 12:30 p.m. and amniotic fluid was clear. So let me see what are your answers. You have to tell which statement is incorrect. Let me see what your answers are. Okay, very good. So most of you know that means how to read a partogram, because most of you are answering this question correctly. The correct answer is C. So let me quickly tell you how you read a partogram. See, whenever a question comes on partogram, there are 3 parts of the partogram which have to be read. One is the upper part of the partogram which has to be read, right? This upper part. Then you have to read the middle part, and then you have to read the bottom part, right? Upper part of the partogram, it gives you information about fetal heart rate, right? Fetal heart rate is plotted with the help of these dots. And after every 30 minutes, you are going to plot the fetal heart rate. So each square over here is going to represent 30 minutes. Right? So that is the first thing which you plot on a partogram at the top. Apart from filling in all the details, that what was the name, what is the gravida, parity, apart from that, that is the first thing which is plotted on a partogram at the top. Then the second thing is about amniotic fluid. When you are writing about amniotic fluid, there are certain symbols which you use, where I means that the membranes are intact. I stands for membranes intact. A stands for absent liquor. C means clear fluid. B means blood-stained fluid. And M means meconium-stained fluid, right? So if membranes were intact when a patient came, you are going to write I, and then you are going to write the time. You are going to note the time when the membranes got ruptured, or whether you artificially ruptured them. You are going to write that there as well, right? So over here, you can see when the patient came, it is I, that means the membranes were intact, and then ARM was done and you got C. That is clear fluid was obtained, right? Now, the middle part of the partogram, it tells you about the progress of the patient. Here you plot dilatation of the cervix and the time interval, right? So in the middle part of the partogram, there are 2 lines which are drawn and given on the partogram. First line is alert line. Second line is action line. And the time duration between them is 4 hours. You can see that the time duration between alert line and action line is 4 hours. That is one very important thing which you have to remember. The other thing which you have to remember is that each big square on partogram, this big square is representing 1 hour. The small squares are representing 30 minutes, right? Now, third thing which you have to see over here is that whenever a patient comes to you in a modified WHO partogram, there is no latent phase. You are not going to plot latent phase. Your markings begin from 4 centimeters dilatation, right? So according to WHO or according to partogram, just now also I told you that active phase begins at 4 centimeters dilatation. So you are going to mark only the active phase. And when you are going to mark the active phase, the first marking will be on the alert line or to the left of alert line, whatever option is given. If on the alert line is given, that's the best answer. But one question I'm going to discuss with you where on the alert line option is not given. So then the best answer will be that your first marking will be towards the left of alert line, right? Have you understood? Now, as the patient's dilatation is going to progress, I am going to keep on marking the dilatation. Always the dilatation has to be marked with X, right? So over here, you can see that patient came at 5 centimeters. We have marked an X and the progress is marked by another X. Now I am going to join these two X's and I'm going to see whether the progress of the patient is lying to the left of alert line, whether it is lying between alert and action line, or whether it is lying to the right of alert line, right? If the progress of your patient is lying to the left of alert line in this area, right? This means everything is normal. The progress of your patient is normal. If the progress of your patient is lying to the right of alert line, that means in between alert line and action line, that means now you should be alerted. Something abnormal is happening. And if you are sitting at a primary center, this is the time you have to refer your patient to a higher center. And the moment the progress of your patient crosses the action line and lies to the right of action line, now this means some action has to be taken depending upon the diagnosis, right? So in this partogram over here, you can see that the patient's progress is lying to the left of alert line. It has not crossed the alert line. That means this patient's progress is normal. This is not the original partogram. This is just to explain you that I'm showing you this partogram, right? Now, suppose if the progress of your patient is something like this, and there are two lines drawn there. One line is joins the X's and one line joins the circles. Please disregard this line. This line is telling you descent of fetal head. And these days, we do not look at the descent of fetal head. So even if it is marked on a partogram, do not think anything about it. Only look at the line which joins the cross marks, right? As you can see, this line which is joining the cross mark is towards the right of alert line. And finally, this line has crossed the action line, right? Can you see this line over here? It is towards the right of alert line. It is between alert line and action line. And finally, this line has crossed the action line. That means in this particular partogram, the progress of the patient is not normal. Have you understood the middle part of the partogram? Right? Now the bottom part of the partogram. In the bottom part of the partogram, we are going to plot the number of uterine contractions which a female is having in every 10 minutes. Each box represents 1 contractions. So over here, you can see this means that there are 3 contractions which are happening in 10 minutes, right? Over here, you can see this means there are 4 contractions which are happening in 10 minutes. Now, not only in this boxes, you will come to know the number of contractions, you will also come to know about the type of contractions. If the duration of the contraction is less than 20 seconds, then I am going to make circles like these dots in the box, right? So whenever I see that dots are made in the box, that means the contractions were very mild and they were lasting for less than 20 seconds. If I see that there are oblique lines which are drawn in the box, that means contractions are moderate and they are lasting for 20 to 40 seconds. And if I see that there is a solid color which has been done to make the box, then that means the contractions are strong contractions which are lasting for more than 40 seconds, right? So dots means mild contractions lasting for less than 20 seconds. Oblique lines means moderate contractions lasting for 20 to 40 seconds. And solid coloring means strong contractions lasting for more than 40 seconds, right? Apart from contractions, in this bottom part of the partogram, you will also write whether you are giving oxytocin and how much oxytocin, what is the pulse of the patient, what is the BP of the patient, what is the temperature. All this information also has to be filled in, right? So this is the basic about how to read a partogram. And if you have understood this, now go to this partogram which was here. Now, in this partogram, what you are seeing is that patient came to you when she was 4 centimeters dilated and it has been marked with an X. And the time was, at that time, she came at 10 o'clock, right? So at the time of admission, Preeti was 4 centimeters dilated. This statement is correct. When she came, she was having 2 contractions which are marked by dots. There were 2 contractions in 10 minutes, and dots means that they were mild uterine contractions. So this is also correct. Progress of the patient was normal. So let us see how the line joining the X's. This is one X, this is another X, this is another X. So the line which is joining the X's, is it showing you normal progress? No. This line is lying in between alert and action line, and finally it has touched the action line also, right? So the progress was not normal. ARM was done at around 12:30 and amniotic fluid was clear. Yes, ARM was done at around 12:30. Yes, it was done at around 12:30, and the progress and the just let me draw it properly. So ARM was done at around 12:30 and the Liker was clear, represented by this letter C, right? So all this is right. Now let us see what was done, what problem was happening, and what solution was taken so that the patient delivered normally. So over here, we saw that patient's progress was not normal and it was delayed progress. Why? Because the contractions were very mild, right? At 12:30, artificial rupture of membranes was done and oxytocin was started. Now, when artificial rupture of membrane was done and oxytocin was started, then contractions became moderate. And because contractions became moderate, her progress started improving. And finally, she had strong contractions and this patient delivered, right? So the problem here was mild uterine contraction, and that is why this was dealt with doing artificial rupture of membranes and by starting oxytocin. So always, whenever the action line is touched, that does not mean that you have to do a cesarean section. Action, as I told you, depends upon what problem is there, right? So in this case, problem was not good uterine contractions, and the moment you dealt with not good uterine contractions, the problem was solved, right? Okay. So this is a question: when a patient in labor presents to us for the first time, where on the partograph will we plot the cervical dilatation? Option A, left of alert line. Option B, between alert and action line. Option C, right of action line. Option D, right of alert line. So where will you plot? Yes, you all are right that you are going to plot it on the left of alert line. Best answer would have been on the alert line. If on the alert line is not given, it will be on the left of alert line. Very good. Next question. A midwife at a PHC is monitoring pregnancy and maintaining the partograph of pregnancy progression. At how much cervical dilatation should the partograph plotting be started? So at what time, at what dilatation are you going to start the partogram plotting? Tell your answers quickly. You are going to start it at 4 centimeters. That is C, option C. So whenever they ask you about partogram, whenever they ask you about WHO, always remember that partogram plotting begins from the active phase, and active phase as per WHO or as per the modified partogram, it begins at 4 centimeters dilatation. But for all clinical questions, it begins at 6 centimeters dilatation. Now, instead of giving you a normal partogram, they can give you a WHO simplified partogram, right? So this over here is an image of WHO simplified partogram. Patient should be referred to higher center if progress of the patient lies in option A, green zone, option B, amber zone, option C, red zone, option D, none of the above. So as you can see over here, alert line and action line are not marked. I mean, they are not written that this is alert or action line, but you can make out. Again, plotting is beginning from 4 centimeters. So this line over here should represent alert line. And 4 hours away from it, this is another line which should represent action line, right? So I just now told you, if progress of your patient is lying to the left of alert line, that means in this green zone, that means it's a normal progress. If it is lying between alert line and action line, that means in the amber zone, now you patient, as an obstetrician, you have to get alerted. And if you are sitting in a primary center, you have to refer the patient to a higher center. And if the progress of your patient lies to the right of action line, that is in the red zone, that means now you have to take the action, right? So instead of giving you the normal partogram, they can give you a simplified partogram. So the answer over here is option B, that is the amber zone, right? Or the yellow zone. Instead of calling it that yellow zone, they call it as the amber zone. Now, next question, look at the video of the procedure being performed and identify the structure which is not cut at the time of this procedure. Right? See? So what is the procedure which is being done? It is a mediolateral episiotomy which is being given, right? Now that means you have to know the structures which are not cut during a mediolateral episiotomy and the structures which are cut during a mediolateral episiotomy. Please remember that when you give a mediolateral episiotomy, the angle which it makes from the center is 60 degrees. If 60 degrees is not given and you have to mark a range, then you will say 45 to 60 degrees, right? So always mediolateral episiotomy is given at an angle of 60 degrees. And when you give a mediolateral episiotomy, you are going to cut the muscles also. Why? Because the most important muscle, which is the pelvic diaphragm, the levator ani muscle, it hangs like a hammock like this, right? So it has thick fibers here, and by the time it comes in the center, the muscle fibers are very less. So in a median episiotomy, the muscle fibers which are cut are very less. But in a mediolateral episiotomy, muscle fibers which are cut are more. The only and the most important advantage of a mediolateral episiotomy is, and that is the reason why we do it, is that even though no matter how much you stretch, by chance, if a mediolateral episiotomy gets extended, never will it, whenever are you going to injure the anal sphincter. But if a median episiotomy gets extended, you are not careful and you extend a median episiotomy, it can involve the anal sphincter. That is why always mediolateral is preferred. But median also has a lot of advantages. Still, it is not preferred because there can be injury to anal sphincter in a median episiotomy. In a mediolateral episiotomy, there won't be injury to anal sphincter. So obviously, one structure which will never get cut in a mediolateral episiotomy is anal sphincter. Apart from that, what are the muscles which will get cut? Just now I told you that the levator ani muscle, it hangs like a hammock. So obviously, levator ani muscle is going to be cut when you give a mediolateral episiotomy. So levator ani muscle, it is made up of two muscles, pubococcygeus and iliococcygeus. Ischio-coccygeus is not a part of levator ani muscle. So ischio-coccygeus will never get cut when you give a mediolateral episiotomy, right? So this is how levator ani muscle is. So number one muscle which you are going to cut when you give a mediolateral episiotomy, it is the levator ani muscle. The deepest muscle will be the levator ani muscle, and the iliococcygeus and pubococcygeus will be cut, right? Now, which other muscle are you going to cut? You are going to cut this yellow muscle over here. This yellow muscle over here is pubococcygeus muscle. So the second muscle which is getting cut is the the bulbospongiosus muscle. So the next muscle which you are cutting is the bulbospongiosus muscle, which is also called as the bulbocavernosus muscle, right? Then the third muscle which you are cutting is this muscle which lies over here like this. There is a muscle which lies like this. These muscles are the superficial and the deep transverse perineal muscle. So you are cutting the levator ani muscle, the iliococcygeus and the pubococcygeus. You are cutting the bulbospongiosus muscle, and you are cutting the superficial and the deep transverse perineal muscle. Apart from that, over here on the superficial and deep transverse perineal muscles lying are the pudendal nerves and pudendal vessels. So you are going to cut them also, right? Now the muscle which is not getting cut, number one is ischio-coccygeus, because ischio-coccygeus is not a part of levator ani muscle, and this blue colored muscle is not getting cut. This blue colored muscle which I have drawn is ischiocavernosus muscle. So remember, the two muscles whose name begins with ischio are not cut. Ischiocavernosus is not cut, and ischio-coccygeus is not cut when you give a mediolateral episiotomy. Obviously, external anal sphincter is not cut when you give an episiotomy, right? So these are three structures which are never cut when you give an episiotomy. If you remember the name of the muscles which are cut, well and good. If you cannot remember the name of the muscles which are cut, remember the ones which are not cut. So the ones which are not cut are the ones whose name begins with ischio, ischiocavernosus and ischio-coccygeus, right? So here the options were option A, bulbospongiosus, option B, ischiocavernosus, option C, iliococcygeus, option D, transverse perineal. I told you the names which begin with ischio are not cut. So option B is not cut. And this is an AIMS question, right? Now, the instrument which you use to cut, to make the episiotomy is an episiotomy scissor. In an episiotomy scissor, you are going to see that there will be an angle over here, right? And this will have blunt edges. This will not have sharp edges. So it's very easy to recognize a episiotomy scissor. Another scissor which you have to recognize is the umbilical cord cutting scissor. This is a spoon-shaped scissor like this. Very typical image. You can never forget it if you've seen it once. And this over here is an umbilical cord clamp, right? So this is all the images which I wanted to tell you related to the labor in OBS. I will be taking one more session with you in which we will be discussing rest of the other important images in OBS, and that session will be in the first week of April, right? I will also discuss the gynae images, which will again be somewhere in the third week of April. Ma'am, please provide slides PDF. That I'll do. I'll provide you all the slides PDF, and I will also upload this video on YouTube on the Marrow channel. It will be there so that you can revise. I hope you people have understood. And if there is anything which you want to communicate to me, or your criticism is more than welcome. And your feedback for this lecture is something which I am looking forward to. So please do not forget to give me your feedback on drsakshiarora@gmail.com, right? I hope all of you take a lot of benefit from this session. Thank you so much. See you again in April. And in the meanwhile, keep studying. Take care, all of you.
Thank you so much, ma'am. And it was a great session. And as discussed by ma'am, you all will receive the mail with the details of the same. Thank you so much for joining us today. Thank you, ma'am.
Thank you. Thank you so much. Someone has written about rapid revision for FMGE. Rapid revision, I've already taken 2 sessions. One is rapid revision in gynae and one rapid revision in OBS. Both those sessions are on Marrow's YouTube channel. So you can go and have a look there. If there would be any change which I want to communicate, I will communicate to you again through YouTube. Right? Okay, take care.
Once again, thank you so much, ma'am.
Thank you. How am I to log out?
We'll end the meeting straight away.
Okay, okay.